Fantastic. Well, we better get started. Welcome, everybody. Thank you so much for joining us. We are right on time, which is amazing work. Thank you so much for joining. And welcome to everybody online as well. Please feel free to take your virtual seats, and everybody in here, take your seats and get nice and comfortable for what we have to share today. Joining us in Brussels, beautiful weather. I'll say that I brought the weather with me from the UK, of course. It's always beautiful there. But again, thank you so much for joining us on the PANACEA project on education on Placebo, the final event, which is going to be absolutely fantastic. Some brilliant content for us to all share. Just before we begin, more relevant for people who are in our live audience today. Fire exits are right behind me. There's no planned drills today, so if the alarm does go off, I'll be first out of there and you guys can follow on behind me. I'll make sure I'll leave it open for everybody. The toilets are just as you've entered in through the main door, just to the right side, down the corridor and kind of behind this screen as well, if you need to go during the session. We don't have any planned or scheduled breaks today, so please feel free to leave at your own accord and make your way back in when you have a chance to. And of course, throughout the day, we have many presentations, a couple of hours. So 2 hours is what we've planned. So hopefully we will be done by that point and we can join everybody in the foyer for our social networking kind of time, which would be really interesting for everybody. For everybody who is online, please feel free to engage in the session as well. Of course, you will have a chat function, a Q&A function as well, for you to submit questions to our speakers today. We will likely go through those and we will moderate those throughout the day and collect those ready for the panel session towards the end of the session, where we will be submitting questions from our online audience and the live audience as well to our panelists to get the discussion flowing and get talking about the project and the important work that's being done. The materials from the PANACEA project will also be available throughout the day via several QR codes, so feel free to scan those when they're on screen as well. And again, as I mentioned, we will be continuing and finalising the event in the social coffee afterwards. So thank you again, of course, for being here. We, amongst our all esteemed guests, both in person and online, I'd like to give the platform to two individuals who have joined us today. We appreciate their presence for today's event and believe that there is huge relevance for them and how we can collaboratively better the management of placebo and nocebo within clinical practice. So I'd first like to introduce Mark Hermans, who is Officer for European and International Affairs in the European Union of Medical Specialists.
Good morning, everybody here in the room and online. Very welcome to this session. And thanks for the organizers for inviting UMS, the European Medical Specialists Union. UMS, just a bit clarification what UMS is all about, because I think that UMS is not really well known all over Europe. UMS is an organization promoting the highest standards in postgraduate training of medical specialists and their continuous professional development, continuous medical education, and the quality of practice. That's very important. These are the three pillars our activities always are built upon. So these three focuses, let me shortly clarify them. The high quality standards for postgraduate training are laid down in documents approved by our members, General Assembly, and they are addressing all training requirements for each specialty listed in the so-called Annex 5 of the EU regulations. These documents stipulate the requirements we think necessary for training content, trainees, trainers, and training institutions as well. And of course, also the follow-up of all these processes going on. UMS, the second pillar, tries to safeguard the quality of programs for postgraduate training for professional development, continuous medical education. And we do this through EACME credits. EACME stands for the European Accreditation Council for CME. And these proposals are sent to the Secretariat. Then they are judged by a panel, and if they're approved, the organizers can say that they have EACME accreditation. They get a number of accreditation points, and our colleagues can go to the national authorities and join it to their portfolio for getting or maintaining their accreditation in their own country. The third pillar is the quality of practice, and that's the biggest, the most difficult aspect of our task, because as many of you might know, that the health issues are still a very big part of the portfolio of the individual member states. EU as such has quite a low impact on the health issues. Although we were confronted with this during the COVID pandemic, and then we saw that a joint action, commonly shared initiatives have a huge impact. Just remind the vaccination programs, the vaccines that have been made available through activities of the EU. So this pandemic clearly illustrated how necessary consultation is necessary. Concerning the subject of today, it's quite evident that every single doctor is confronted with pain in his practice. So we think it's so general that nobody thinks about placebo and nocebo effects. And it made me think that indeed we are poorly trained in the theoretical and practical aspects of these issues. So I was very curious to know what the outcome of the PANACEA consortium studies will bring forward, because this might help the UMS and its colleagues. About 2 years ago, we established an MJC. An MJC stands for Multidisciplinary Joint Committee on Pain Medicine. It started by an initiative of the anesthesiologists, but then, of course, other specialties said, well, dear colleagues, anesthesiologists, you're not the only ones who are treating pain. We are also treating pain, rheumatologists and other neurologists, psychiatrists, etc. They were all involved, so we decided to establish such an MJC. And I think that the subject of today will certainly be of an interest, and particularly the tools that you have been producing. I'm very curious to learn about these tools and look forward to this. So within the conceptual framework, I think the place of placebo and nocebo is really very deserving all of our attention. When I went through the literature that was made available to me, I thought my first conclusion was we still need a lot of research, because at this moment to put all the findings of the study into clinical guidelines will be very difficult, but it's worthwhile, certainly worthwhile to look at it. At this moment, everybody is treating pain from his own perspective, and certainly when it comes to placebo effects, nocebo effects, everybody is relying a bit on his or her experience, intuition, gut feelings, and I think we might go on in a very more broad trajectory in collecting data about side effects commonly seen in the drug application. So the outcome of today's meeting, I'm really curious to look forward to a further trajectory because it is opening a field of interest that has been neglected. And so I hope you all enjoy the meeting of today and that you have a fruitful meeting here in the audience in the room and online. So thank you very much.
Thank you, Mark, for sharing those words. We also have, as previously mentioned, another guest with us who I'd like to introduce Pedro Barata to the stage, who is Vice President for the External Affairs of the European Medical Students Association. Thank you so much for joining us, Pedro.
Hello. First of all, thank you for the invitation and thank you for including medical students and EMSA, the European Medical Students Association, in this final conference. This topic is a topic that needs to be assured. And first of all, education is the bridge between what we are today and what we want to become. We all know this. When we want to tackle a problem, we go for the education so that it's not a problem tomorrow. But the bridge that we currently have today is broken, is rusty. Education is outdated and needs to be updated. And it's through projects like this, the PANACEA project, that needs and incorporates learning tools and guides for both practitioners, for teachers, and for students that we can improve what is the guidance of tomorrow. In EMSA, we tackle many problems. We have 6 pillars. I'm not going to mention everyone, but one of our most important is medical education. For us to better improve our practice and for us to better tackle what is medical education, we need guidelines like the ones that we have today. A problem that we are facing is that in the future, there won't be enough doctors to tackle the problems that we have. With the current healthcare shortage that we are facing, we are expected more from us. We are expected more from students. We are expecting more from recent graduates. But we are not ready. We do not feel ready to tackle today's problem, neither tomorrow's problem. And it's through projects like this that tackle problems that we are facing at every specialty, like it was mentioned, has them, that we can come together and have a joint action. I also want to thank the University of Bologna and the PANACEA team for this project. Another problem that we are facing is, like I said, that medical education is outdated. We need more learning tools. We need medical education, digitalization. We need evidence-based learning materials and learning approaches. And for example, like in the PANACEA project, learning platform and e-learning platform and direct feedback and instant feedback is something that we need to tackle. We need to tackle as well what is the bridge between theoretical content and what is the practical knowledge that we use and that we have to use every day. Today, students tackle a lot theoretical knowledge. It's important, yes, but we are not ready for what is the clinical practice that we need to. It's important for students to know what is placebo, what is nocebo, but it's also important for them to know how to use it. It's important to know that placebo is not only a psychological effect, it's also physiologic, but we need to know how to use it to reduce, for example, over-medication, how to use it to reduce side effects, and how to use it to improve healthcare. Another problem that we are facing in Europe is that medical education is not standardized. A degree in Portugal is equivalent to a degree in Belgium or in Spain. Nevertheless, our medical curriculums are disparate. We need guidelines, European guidelines, on what defines medical education. And the current guidelines that we have is that medical education is a training, either a 6-year training or a 5,500 hours. This is not enough. When we have the multiculturality that we are facing, when we have the mobility between countries and professionals that we are facing, we need to have some bases. Of course, diversity is important, but we need to have core fundamental subjects that align us. And for example, through projects like this, that gives us evidence-based knowledge and how to utilize it, it's not that hard to accomplish it. Once again, education is the bridge between what we are today and what we want to become. For that, we need a new bridge, a better bridge. And for that, we need consortiums like this. Thank you very much once again for the invitation.
Thank you, Pedro. And thank you, everybody, for joining. Really important words, and it's brilliant to have them heard here at the meeting today. So thank you so much for that. Before we begin with the main content, I'd like to just take a moment to invite Katia to lead us in sharing a thought and remembering an important member of our consortium, a leading light in this field before she passed away last year. Katia.
Thank you, Nathan, and good morning to everyone to be here in presence and virtually. And I wanted to thank each of you for being here and for your interest in the fascinating and clinically relevant phenomena of placebo and nocebo. And today is a special moment as our consortium finally has the opportunity to disseminate our work to a broader community. However, it's with profound sadness that we recognize we cannot do this without remembering one of us, Andrea Heves, who was taken from us too soon last August. So I kindly ask you to allow us a moment of reflection to honor her memory and to share with you who Andrea was, as well as the profound impact she had on the study of placebo and nocebo and on the PANACEA project and on her colleagues, collaborators, and of course, students. Andrea Heves was a leading international expert in this field. She was full professor of health psychology at the Institute of Psychology at Leiden University and served as a president of Society for Interdisciplinary Placebo Studies. And in this role, she strengthened the identity of our global research community, fostering collaboration and shared sense of purpose. Andrea was also the founding director of the Interdisciplinary Placebo Study Center, where she created an excellent hub for research, training, and clinical innovation. And under her leadership, the center became a model for integrating placebo science meaningful into healthcare. She authored over 400 peer-reviewed publications, receiving more than 13,000 citations, so a testament to her scientific influence and contribution. Her work significantly advanced our understanding of placebo and nocebo phenomena, shaping how these effects are understood and applied today. Beyond her scientific achievement, Andrea was a person of immense passion, curiosity, and humanity. She was a vibrant and captivating speaker, a true role model of scientific integrity. She was deeply committed to mentoring young scientists, always generous, encouraging, and inspiring the next generation. Every encounter with Andrea brought energy, wisdom, and joy, and her smile and the simple phrase, "Let's do it together," will stay with us forever. We all share not only work, but also moments of laughter, friendship, and even dancing. It has been a privilege to meet and work with Andrea. She will remain in our hearts as a shining example and an ongoing source of inspiration. The PANACEA Group, the scientific community, and the society at large own her great depth. We will deeply miss her presence, her kindness, and her luminous spirit. If clinical practice continues to advance through a deeper understanding and implementation of evidence-based approaches to placebo-nocebo phenomena, much of that progress is due to her groundbreaking work. Her legacy will continue to shape the future. And let me share a personal note. I like to remember Andrea, her energy, her vitality, her courage, and the incredible strength she always showed, especially in her last weeks of life. And I like to do so with an image, her beautiful hands, which were both a literal reflection of her grace and warmth, and a powerful metaphor for a guiding spirit, our ability to connect research and clinical practice, mind and body, discipline and people, enthusiasm and courage. So we miss you, Andrea, and sorry for my emotion. Thank you.
Thank you, Katja. The beautiful words. Thank you for sharing. Okay, so let's continue with the content. We'd like to know a little bit more about everybody here, of course, in person and online as well. So please feel free, you should be able to see a QR code on the screen. Please feel free to scan this. I'm just going to very quickly move it, which might frustrate a lot of you who are trying to get that in the camera shot. But please let us know where you are from. You should be able to drop a pin onto the European map. Might be quite difficult for some specific areas to be exact in terms of where your house is inside your country. I had a go earlier. I'm from the northeast of England, so I didn't do too bad in terms of getting the pin exactly where we are. But it's fantastic to see some spots where everybody is hailing from watching online, of course, and from in person. It's nice to see that we're already getting a good spread. I was informed not too long ago we have 242 attendees online. So it might be that we start to see some good groups here, and I can see that the system is starting to be lazy and group people together in specific areas. But it's great to see that we have so many people broadly across Europe as well. Amazing stuff. So we're just going to continue. I want to make sure that we find out a little bit more about everybody, actually. So now on your systems, it should have changed to, or should change just in a second once I push this button here. We also want to know what your discipline is. Please let us know your area of expertise. Perhaps your speciality within your discipline, be as explicit and as expressive as you like. We can see psychology straight up in the forefront, physiotherapy jumping in, international education, pain, of course, pharmacology, physio, research physician, lots and lots coming through, which is brilliant. It's great to see so many different disciplines included today. Osteopath we can see coming through there as well. Lovely. Very, very great to see. And one final point that we would love to hear from you is the following, once I am able to use my skills, my computer skills. A couple of questions for you, if you don't mind. So we'd first like to know, on a rating of essentially 0, extremely poor, to 5, what we would consider as exceptional, what was the quality of placebo education in your training? And then once you've answered that one, maybe we can ask, what was the quality of the nocebo education in your training? And I think this might set the scene a little bit for today's content as well. And I'm sure it would be really interesting for everybody, both online and in person, to see where we're kind of sitting. And we can kind of see that very broadly, nocebo education, sort of self-reported, extremely poor 1.8, sitting a lot lower than the much more dispersed placebo education, which tends to edge a little bit more towards exceptional, which is interesting to see. I think this may be a surprise. This may not be a surprise to some of the attendees today, but it's great to see some of the knowledge that currently resides around everybody who's attending this today. Fantastic. Thank you so much for engaging. I would now like to move towards our first presentation. So our first presentation comes from a member of the consortium. I'd like to invite Zdeněk Bambel to the stage to essentially talk to us about the current understanding of placebo and nocebo effects. Zdeněk.
Good morning. Thank you for organizing it. It's my pleasure to say a few words about what actually placebo is, how it works, and whether it actually works. So first, actually, the first part of this talk would be the concept. So, what is placebo? And this is actually the worst part. So, this is the most difficult to say what actually placebo is, because as many scientists we have, probably every of them would have their own placebo definition. But what I think everybody would agree is that placebo is much more than we usually think about. Because usually we think that placebo is an inert intervention, for example, sugar pill or saline injection. Some would say maybe that sham surgery also. But we know that placebo is much more, that actually all the contextual factors that are present during the treatment may be seen as placebo factors. So now we think that placebo is something much broader, that every psychosocial stimuli that affects treatment is placebo. They can be seen as placebo. And regardless of whether it's just an inert intervention, like in this narrow sense, or contextual factors, we know that they can both help and they can also decrease the effectiveness of treatment. So when we speak about placebo effect, we think that, this is of course the most known phenomenon inside placebo field, that placebo effect is a positive health change in symptoms. But we should know, and this is not so very common knowledge, that placebo can also induce nocebo effects. And this is especially important in treatment, because some of the side effects of even active treatment can be due to a nocebo effect. And what I think is really important is that placebo and nocebo effects are real. And although we know that, of course, the most of the studies done on placebo were done on pain, in pain domain, so we have a lot of evidence, actually huge evidence, that both placebo and nocebo effects are sometimes small, sometimes moderate, but sometimes even very big. Actually, there are some studies, even meta-analyses, showing that sometimes placebo effects are as strong as effects of active intervention as it is, for example, in case of paracetamol for low back pain. Effectiveness of placebo and paracetamol for low back pain is exactly the same. So I think it's important. But more importantly even, placebo effects and nocebo effects are observed across many other symptoms, not only pain, and also across many diseases. You can see some of them here. Our scoping review that was conducted within the PANACEA project also shows it very well, that placebo and nocebo effects can be observed across many other symptoms and diseases, not only in pain. And the question, of course, arises, how is it possible that something that is actually either inert or is just the factor, is just the, I would say, for example, doctor's code, how it can work? And there is huge amount of studies on this issue, and the most important mechanism of placebo effects is its expectation, and I will talk about it in a moment. And expectations are usually induced by verbal suggestions, but they can also be induced by classical conditioning, operant conditioning, observational learning. Sometimes these learning processes can induce placebo effects even without expectations, but usually they induce placebo effects through expectation change. And also what we know, what we acknowledge now, much more than earlier, that emotions, not only cognitive factors like expectations, but also emotions are important, especially negative emotions. And I will talk about each of these issues in a moment. But what I will not talk about, because I have just 15 minutes, so it's not a lot, I will not talk about physiological mechanism, because it's a huge part of the studies on our knowledge on placebo effects. But what I would like just to mention is that all these learning processes, all these cognitive and emotional factors that induces or mediates or moderates, depending on the studies, placebo and nocebo effects are not just subjective effects. They usually have some important correlates in physiological processes, and that physiological processes are also the mechanisms of placebo and nocebo effects. So let me start with expectations. And one of the most prominent theory here is response expectancy theory that was proposed by Irwin Kirsch exactly 40 years ago in 1985. So and it's quite a simple theory, because it says that when we expect that something will happen with our body, with our mind, it will happen. So when we expect that the pain increase, then it increases. So when we expect that the pain will decrease, it decreases. So it's quite simple theory, but it's the theory that is very well. There's a lot of studies supporting it, and what is, I think, also important is to notice that when we think about response expectancy from this theory, from Kirsch theory, we think about, we have in mind intrapersonal expectations, not interpersonal. So we think that, this is the expectations concerning ourselves. So if we expect something from us, it's response expectancy. But if we expect something from others, it's interpersonal expectations. And they are, of course, also important in clinical context. So if the doctor expects that we will feel better, it may help. But in this theory, this theory is narrowed to what we expect from us, from our body, mind. And a lot of studies show that expectations either induces placebo or nocebo effects, but what is very important, they can also affect active treatment effectiveness. So when we expect that active treatment will help us, it may help us better than when we expect that it will not help us. When we expect that pain treatment is actually an opioid, it may help us more than when we expect it to not to be an opioid. So this is very important, that even active interventions can be affected by our expectations. But generally, how we create expectations, from where expectations come from. So there is a very prominent learning model of placebo and nocebo effects. It's a model proposed by Coloca and Benedetti. And generally, the model says that placebo effects are learning phenomena, and there are different learning processes like verbal suggestions, observational learning, classical conditioning can induce changes in our expectations, and these changes in our expectations are the key factors of inducing both placebo and nocebo effects. And the most studies, the most data on these processes is coming from verbal suggestions. So in most studies, verbal suggestions are used to induce either placebo or nocebo effects. So it's quite simple. So we say that, for example, this is a potent painkiller, or that is a strong antidepressive drug, and although it is placebo, this information sometimes it's coming from advertisement, sometimes it's coming from the doctor, sometimes it's coming from the information on the medicine. So this information can create both placebo and nocebo effects. But also, this verbal suggestion can affect, of course, active treatment through expectations, as I said before. Interestingly, as we use pure placebos, so these are in this narrow context, when we use, for example, a sugar pill or saline injection, we usually say, okay, this is an active treatment. And from ethical point of view, it's at least problematic. Actually, it should be abandoned, but it's still we know from studies that practitioners, doctors use pure placebos, and they inform that it's actually an active treatment. But this ethical problem can be resolved with what we call open-label placebo, when we inform honestly patients that we use placebos. This is also a kind of verbal suggestion, and very strong and very extensive verbal suggestion, because we don't say that this is an active treatment, this is a potent painkiller, just one sentence like in deceptive placebos. But in open-label placebos, we inform patients and participants in the studies what placebo is, why it works. So we inform them about the mechanism, and most importantly, we inform participants that it works, that we have a lot of data showing that placebo is effective. This is usually information like, 1 page or even 2 pages, so it's much longer than just saying this is an active painkiller. And what we observe in studies is that it works similarly to deceptive placebos. So it's so this verbal suggestion, the open-label verbal suggestion of placebo, can be as effective as deceptive placebos, which I think it shows not only the power of placebos, but more importantly the power of verbal suggestion. And studies show, and this is one of the meta-analyses, one of the recent meta-analyses on verbal suggestions, that first of all, they work, so the words can heal. So verbal suggestion can induce placebo effects in both narrow and broader sense of contextual factors. But importantly, that words can also lead to some negative consequences, nocebo effects, or nocebo or just side effects of active intervention. So we should be very cautious when we communicate with patients. Another learning process is classical conditioning. Within this process, placebo is seen as a conditioned stimulus. So at first it was just neutral one, but because it was paired with active intervention, then it started to induce similar effects. Like with if we take paracetamol in a form of round white pill, then we and then for some times, and then we just use the same pill but without paracetamol, it may work. And why it may work? Because of classical conditioning. And we know that classical conditioning may induce both placebo and nocebo effects, and it shows that patients' previous experiences are very important, and they can induce both, and they may contribute to both placebo and nocebo effects. And what may seem paradoxical is that using effective active treatments is essential in the success of active interventions, future active interventions, but also, of course, of placebo effects. So positive experiences with active treatment may induce stronger effects of active treatment, but also may induce placebo effects when we use placebos. And the opposite is true with negative experiences, which may contribute to nocebo effects. Another important learning process is operant conditioning. Here we don't have a lot of data within placebo field, but we know from the other fields that rewards or say positive reinforcement may change the effects of, for example, when we take placebos and it helps and we get some positive reinforcement from it, it can be chosen more frequently. And the opposite may be true with negative effects. And the studies, not many studies, just a few already published, shows that reinforcement may both induce and enhance placebo effects, and that it is important to guide patients in recognizing positive effects from placebo, but also from active treatments. And when negative effects appear, then they may be interpreted as the effects of action of a drug to convince the participants, the patients, that actually the treatment is working. And the last process is observational learning. We, the people, are social animals, so we learn not only from our experiences, but also from experiences of others. And when we see that the treatment works for somebody, it can create expectations, and it can work for us. Of course, both in a good and bad direction, so it can induce both placebo and nocebo effects. And recent social learning model of placebo effects showed that this observational learning is a bit complicated, that for example, the models matter. So models, for example, sex of the model, social status of the model, competence, but also self-confidence of the model. So the person that we observe may contribute to the effects, but also the empathy of those who are observing may be of importance here. And the studies, this is the last meta-analysis on observational learning, shows that modeling, including video modeling and verbal modeling, can induce both placebo and nocebo effects, and that careful selection of models is important, and also that we should limit actually the contact of patients with those who experience negative effects of our treatment worsening, because they may learn to also experience negative effects. And last but not least, recent studies shows that also emotions play here an important role, not only cognitive expectations, that positive emotions may both strengthen placebo effects and also prevent nocebo effects, that negative emotions may strengthen nocebo effect and reduce placebo effects. And these negative emotions that there are studies the most are stress, fear, and anxiety. And we also know that placebo interventions can increase positive emotions, but also nocebo manipulations may increase negative emotions. And recent model, theoretical model based on studies, shows that the most important are anxiety and fear, and those anxiety and fear pre-treatment and also after treatment. So emotional states of patients should be monitored during the treatment. positive emotions should be induced and negative emotions should be reduced. Placebo interventions may be applied to reduce negative affect and induce positive affect as well. And to conclude, what we know from studies so far, placebo and nocebo effects are real. They occur across a wide range of symptoms and diseases. And what we also know, placebo and nocebo effects are learning phenomena, which is good because they can be both acquired, but also in case of negative effects, they can be reversed. And expectations and emotions play important role in information of both placebo and nocebo effects, and they can both moderate and mediate these effects. Thank you so much.
Thank you so much, Przemek. Very, very interesting. I think this is a fantastic slide to leave it on, which is having so many important points, which I think everybody should be learning from today. Moving swiftly on, I'd like to invite Katia Matarazzi to the stage to talk about the project overview and key results. Thank you.
Thank you, Nathan. So, thank you, Przemek, for the overview of the mechanism underlying the placebo and nocebo effect. And my role today is to introduce the PANACEA project, its origins, the need that prompt its development, and how we address those needs. So these needs stem from a fundamental recognition of the clinical relevance of the phenomena. So as Przemek highlights, the placebo-nocebo effect refers to a mechanism that are activated when an individual experiences a change in their health and interact with a treatment. And these mechanisms are aimed at regulating the patient condition and are influenced by psychological, individual, and contextual factors. So placebo and nocebo effects we can consider as regular phenomena in clinical practice. So let me show briefly the clinical area most involved in placebo-nocebo research, as Przemek has already highlighted before. Based on the number of reviews, meta-analysis, and observed side effects, psychiatry and neurology emerged as the leading disciplines, followed by gastroenterology, rheumatology, and dermatology. Furthermore, as robust evidence from multiple studies suggests, the placebo effect can account for 50 to 70% of the positive response in some pain treatment. I will highlight some of the key clinical implication of placebo and nocebo effect. These can be categorized into several crucial healthcare areas, including optimizing treatment outcomes, such as enhancing the efficacy of drugs by leveraging psychological and contextual factors that enhance drug response, re-evaluating proper dosage of an active drug to achieve the desired outcomes, and taking care of clinical conditions where no effective treatment is available. So awareness of the placebo and nocebo phenomena promote also personalized medicine, as it becomes important to understand, evaluate, and manage patient beliefs, expectation, and perception, and their influence on treatment outcomes. And to improve communication skills by learning how to explain complex medical concepts and address concern about treatment that our patient can have. and to also recognize the importance of addressing not only the physical aspects of the disease, but also the psychological and social dimension that influence treatment outcomes. The next key implication addresses the importance of assessing the treatment efficacy more accurately. This begins with improving evidence-based practice and critically evaluating research and clinical trials. Additionally, improving the management of side effects and potential treatment discontinuation is crucial. Furthermore, another key implication pertains specifically to clinical research. So proper control and mitigation of placebo-nocebo effect help ensure that observed outcome truly reflect the intervention to pharmacological or therapeutic impact. Despite the growing body of research on placebo and nocebo and their recognized clinical relevance in terms of effect in various medical areas, this remains a significant gap in knowledge and practice among healthcare professionals. As revealed by a series of studies, healthcare professionals declare to have awareness about these phenomena, so about placebo-nocebo effect and their potential impact in clinical practice. They report implementing placebo intervention. However, they do so without a solid foundation of knowledge or adherence to evidence-based guidelines. Furthermore, many healthcare providers are frequently unprepared to recognize, address, or mitigate the occurrence of the nocebo effect. And notably, there are a large variation in understanding and application across discipline and clinical area. So numerous studies increasingly demonstrate that targeting educational tools can significantly improve healthcare professional understanding of placebo and nocebo phenomena. However, if we look into current university curricula, at least in the medical context, the focus remains largely within the realm of pharmacology, where placebo is mainly as an experimental paradigm. So its determinants, the factor, and its wide-ranging clinical implications are often overlooked. And this highlights a clear and a urgent need of expanding and formalizing education on this topic, integrating it into healthcare training programs, and to promote a broader, more practical understanding that can truly impact patient care. Leveraging this insight and addressing this need, 3 years ago, we established an European partnership and launched the PANACEA project. That is a higher educational initiative funded by the European Union. And this project aims to formalize and expand training across healthcare discipline, fostering a more comprehensive and practical understanding of placebo and nocebo phenomenon and among both current and future healthcare professionals across Europe. Our partnership is a diverse group of European universities, all part of the Una Europa Consortium, and each bringing unique interdisciplinary expertise in placebo and nocebo phenomena, such as pain expert, health psychologist, pharmacologist, physician, and educators. And this esteemed institution include KU Leuven, the University Complutense of Madrid, Jagiellonian University, University of Leiden, and we are proud to collaborate with the European Federation of Pain and an Italian software house for the technological support. So our focus include higher education students, medical, nursing, physical therapy, psychological students, to just give some example, and also residents in healthcare-related fields, and educators and trainees and healthcare professionals. Let's now explore our specific aims and the educational outcomes. The first specific objective was to increase knowledge about placebo-nocebo effect, especially among higher education students, and to guide healthcare professionals in apply this knowledge in clinical practice. So to reach this goal, we have developed comprehensive PANACEA learning materials and clinical recommendations that now serve as a solid foundation of evidence-based knowledge and practical guidance for both student and practitioner. I just want to briefly point out this slide, which shows some of the main outputs we have produced, so the learning materials and how they are structured and several components in order to enhance, to improve the learning experience. But after my presentation, Ariana and Stephanie can go deeply into our tools. So we have also the clinical recommendation for clinicians aimed at optimizing placebo effect and minimizing nocebo effect. And moving to our second educational goal, one of our main focus is to address the gaps in teaching about placebo and nocebo effect within the healthcare curricula. So to this end, we have developed a syllabus that serves as a comprehensive guide for educators, allowing them to effectively integrate these crucial topics into the teaching program. And our syllabus is structured into 8 modules, and each designed to cover a key aspect of placebo and nocebo effect. And it begins with the basic concept and history, to move to mechanism, assessment, clinical application, influencing factor, ethics issue, and open label placebo approaches. So importantly, each component of the syllabus corresponds directly to the learning materials I mentioned earlier, ensuring a coherent and integrated educational experience. Our third goal centers on fostering innovation in learning. Specifically, we developed and enhanced methods for more effective teaching of placebo and nocebo effect and learning, of course. And to achieve this, we have created the PANACEA web app designed to improve the learning experience through interactive features and gamification, and making this concept more engaging and accessible. So the upcoming talk after mine will showcase the web app, its content, and guide you on how to navigate and explore it. So the educational tools include also practical activities designed to develop core skills. For instance, participants will engage in role-playing exercise, such as describing a medical procedure or prescribing a treatment, manage the side effect. And additionally, the actives feature critical thinking debate, where learners will discuss and develop strategies to minimize placebo effect in clinical research, evaluate their pros and their cons, and consider also ethical aspects and reach group consensus. This image presents the feedback from external reviewers regarding the educational tools we have developed, and their opinion highlight key aspects such as relevance, clarity, accuracy, and consistency. And I would like to take this opportunity to thank our 3 external reviewers. And the PANACEA has formalized 3 educational formats are available for all. These formats differ in structure and intensity, but all are based on the educational tools developed by the project. So PANACEA Day sessions are hybrid events with flexible duration, typically lasting from 4 to 6 hours in a single day. They can be tailored for student, healthcare professional, or both, and are designed to align with the European vocational education and training. So the summer school, on the other hand, is a more extensive program designed to provide deeper engagement over multiple days. And the most structured educational format is a 3-credit university-integrated course designed to be incorporated within undergraduate curricula, built upon the comprehensive PANACEA syllabus, and it combines lecture with group-based experiential learning activities. We have implemented this course at the moment during the project life at 2 of our institution partners, so the University of Bologna and also the Jagiellonian University. So now we'll leave the opportunity to explore in more detail the tools produced by the project, which you can use in your activities as an educator or as a current or future healthcare professional. So thank you for your attention.
Thank you so much, Katia, for sharing. Really, really interesting stuff as we continue, of course. And we will see some successes of the summer schools and the in-person educational experiences that we've had a bit later on as well. So now we shall move on, as Katia mentioned there, to Ariana Bagnis and Stephanie Mewis, who will explain and demonstrate the web app for everybody. Thank you.
Thank you, Nathan, for the introduction, and hello to everyone, both here and online. Now I'd like to show you the PANACEA web app, one of our main results of the project. So this is our homepage, and from here you can go to several sections. The first one is the learning and training section, which is really the core part of the platform, where you can find all the learning materials. And I will show you later one of them. Then we have the glossary tab, where you can find all the main definition related to placebo and nocebo effect, and you can also download it as a PDF file. We also have a dashboard tab where you can see your learning progress. For example, you can view your score at each module self-assessment. And finally, we have a tab with some information on how to cite the PANACEA web app and its material when you use it. But as I mentioned, the most important section is actually the learning and training section. Here you can find not only the learning modules, but also our scoping review about placebo and nocebo effect. We published recently in Health Psychology Review, and this is a review on the most recent evidence on placebo and nocebo effect with some insight for clinical trials and clinical practice. And you can also find the clinical recommendation, which Stephanie will introduce later. But now I would like to show you one of the modules as an example. Each module follows the same structure, and it's designed to be easy to navigate. On the right side of the page, you can always access the glossary. So if you come across a term you're not sure about, you can always check it immediately without leaving the page. And then we have several tabs with the main content. So the main tab includes some information about the module, so background information about the content, the learning objectives, and the content outline, and also all the references about the module content. Under the chapters tab, you will find the main part of the content, the theoretical content. And it's mainly based test, but of course you can also find some figures and visual examples to clarify the most important concept. You can navigate through the content through these arrows, and you can also click on the references to go to the specific publication if you go more deeper in the content. Yeah, the next section is the Q&A tab, where learners can post their questions and get some answers both from learners and teachers, making the web app a very engaging tool. Then the two next tabs are focused on the self-assessment for learners. So we have two tests. The ongoing test can be taken multiple times, and the learners can get immediate feedback about their answers with some explanation about the correct answer. The final test instead is can be taken only once at the end of the module, and to pass you need to answer 8 out of 10 questions correctly, and if you do, you earn a digital badge, making the web app based on gamification and positive reinforcement learning. Finally, the last tab is about the module evaluation, so learners can give us their feedback about the module, for example, about the clarity of objectives, the clarity of concept, and so on. On the right side of the page, you can also find some extra materials, such as the mind map. Sorry. Where is? Okay. The mind maps that visually summarize all the content. Here you have an example. And you can also find some PDF files with the schematic form of the content, useful both for learners and professors that might want to use in their classes. So basically, the web app is a very engaging environment that combines theoretical content, interactive discussion, and self-assessment tools, making this tool very flexible and engaging. So I hope you will make use of it and you find useful. Now Stephanie will introduce the guidelines.
All right. So thank you, Ariana. As Ariana mentioned before, we have the guidelines under a separate module within the web app, so it's very easy to access. And the guidelines, the recommendations, they are structured around these 5 main domains. So one of which is optimizing the clinician-patient relationship. One is asking about expectations. One, discussing the treatment rationale, discussing risks and side effects, and explaining placebo and nocebo effects to patients. So really trying to provide this full overview of how you can use communication to optimize placebo effects and minimize nocebo effects in daily practice. Before I go into details, I do have to mention that this section is still under construction. So we are currently finalizing the recommendations, and we hope to be able to share them with you soon. So what have we been doing? So in the chapters section, you can find the core of the clinical recommendations. We have a brief abstract where we just provide a few highlights. Then we have an introduction where we briefly explain why these clinical recommendations are needed, why they are important, and how they came to be. Then within the methods section, we explain more about the details. So how did we establish these clinical recommendations? And here it's important to know that there are 2 main aspects of the clinical recommendation. So one is the expert recommendation, so really a general explanation backed by different literature, for instance, reviews, opinion papers written by experts, more the theoretical basis. And then we also did a systematic review where we systematically assessed the available evidence from empirical studies. So really the data that we have on using communication to optimize placebo effects, minimize nocebo effects. So I'm just quickly going to go through that. So within the systematic search, we had about 19,000 records. We screened them all, and we ended up with almost 200 studies, which could be included into the recommendations. And here we have the different domains. So, for instance, you can see the clinical recommendations here. This is really the narrative synthesis. So this is the expert recommendations. We just to highlight a few, for instance, the nurse framework for empathic behaviors, really trying to boost empathy within the clinical encounter to optimize placebo effects. So, for instance, naming emotions, showing that you understand them. And then we have some more structured, really concrete suggestions as well. So, for instance, to optimize placebo effects, you could give reassurance of ongoing care, so showing that you are there for patients. This can help to foster trust. And then, like I mentioned before, we have the systematic search results, so really the backing of these recommendations. And for this one, for optimizing the clinician-patient relationship, for instance, we have the 96 studies that show that these are effective behaviors. So yeah, and we have these for all the different aspects. So also asking about expectations, we again have the expert recommendations followed by the available evidence. And one thing I would like to highlight is that we do not just take quantitative studies into account, but we also gathered the qualitative data. So we have both the quantitative, the effectiveness shown in the recommendations, but also a bit of qualitative, a qualitative perspective, sharing patient perspectives, really showing the reasons why it's important to showcase these behaviors. We also have that for discussing the treatment rationale. So here you can find information on how to talk about different treatments, like what information should you provide. For instance, avoiding either exaggerating or underestimating the treatment results. We have a section on risks and side effects. So how should you communicate about side effects? For instance, like how should you structure the consultation about these side effects, and how could you frame the information? So for instance, one of the things which is found pretty clear in the literature is that you could frame positive outcomes rather than negative outcomes. So saying that 9 people out of 10 do not experience side effects can be helpful, instead of focusing on the more negative information, the 1 out of 10 that do experience side effects. And then the final section I would like to highlight is explaining placebo and nocebo effects to patients. Przemek already mentioned earlier that open label placebo may be effective. And here we provide some information on how to talk about placebo and nocebo effects. So how should you explain it? How should you talk about the mechanisms of action? What is an appropriate way to present this type of information? So it's a lot. It's too much to go into detail now, but I hope that this is providing you with a bit of overview of the work that we have been doing. So thank you.
Thank you for that. Very interesting. You can see that it's a pretty comprehensive offering online. I'll just bring us back into the presentation to continue. Just as a reminder as well, we've had a few questions online, some good engagement online as well, so please continue popping your questions into the online feature so that we can go through them. When we get to the panel, you would have seen as well in the bottom right there that it's not 11 o'clock in the morning. My laptop still hasn't updated, so we haven't gone back in time. We're doing okay. So I'd like to continue now into a component where we like to share experiences from people who have engaged with the materials from the PANACEA project. First, I would like to invite Antonio Portolas to share his insights in this regard.
Okay, thank you so much to the organizers of the meeting and also to the PANACEA project. And then, well, first of all, may I introduce myself? My name is Antonio Portoles, as it has been said, and I am a medical specialist in clinical pharmacology and working in healthcare and having an extensive experience in clinical research. I'm also professor of pharmacology in the University Complutense. Well, and then PANACEA project appears, and then the kick-off meeting began in the 25th of January in 2023, and so all these guys you now know from the project were appearing in my life. Then what did I find in the PANACEA project? Well, I found multidisciplinarity. It was a great team based on psychologists, information technologists, methodologists, nurses, physicians, and clinical pharmacologists, with an impressive background of knowledge, experience, and methodology, and professionality. I also found a very precise project execution, perfectly on time in every task was made, and also innovative teaching methodologies, as has been exposed previously. And at the end, an excellent relationships and also friendship of all the people from the team. What could I contribute to PANACEA project? Well, first of all, the healthcare perspective in my as a clinician. Also the methodology of research, as we use usually the placebo to elucidate the bias and to clarify the specific effects of drugs and therapeutic interventions. Also contributing to discussions, methodology, and documents and publications, as well as organizing the kick-off meeting and organizing the first PANACEA summer school in Madrid. And also organizing and participating in the PANACEA days in terms of teaching, diffusion, and communication of knowledge. And what did we build throughout the PANACEA project? From my point of view, we a huge amount of knowledge materials, also a very proficient teaching tool, the use of innovative teaching procedures, motivation of all the participants, also publishing the knowledge and communications, as well as establishing international relationships, and at the end, the great impact of increasing the advantage of placebo response into the therapeutic activities. And just a word to thank the team from the University Complutense, and I'll thank also again to the PANACEA project, the leaders who gave the opportunity to participate in this very interesting project, and also the organizers of the meeting, and also the Erasmus+. Thank you very much.
Thank you for sharing those insights. I'd now like to jump to an online attendee to share some insights. Ehsan, welcome. Ehsan, can you hear us? Just let us know if you can hear us, Ehsan.
Hello.
Fantastic. It's great to hear you. Thank you so much for joining us here
Oh,
today. If you'd
I'm
like to
sorry, I
share
don't have
your insights, that
audio,
would be great.
so I'm just going to start my talk, if that's okay. So good morning, everyone, or good afternoon. My name is Ehsan. I'm a 6-year medical student who participated in the institutionalized PANACEA trial semester at the University of Bologna, which was a free credit elective within the 6-year Medicine and Surgery International Program. The course really deepened my clinical perspective by placing placebo and nocebo phenomena at the center of patient care. Throughout the course, I got a clearer and more nuanced definition of placebo and nocebo and the real-life clinical effects, which were beyond the simplified examples usually taught in the university curriculum. I learned that placebo effects can contribute to meaningful clinical benefits, and nocebo responses can significantly worsen outcomes. And as a healthcare provider, we play a critical role in managing these effects on the patient. I really appreciated the way the course was designed, making it very interactive and student-oriented, which created an engaging learning environment, which is different to the education that we receive with traditional lectures. Also, a central theme, which I found interesting, was the role of patient-physician interaction in enhancing placebo effects and reducing the nocebo harms. So we would practice this by role-playing clinical interactions with our classmates, and I personally found this exercise really made me more self-conscious about my wordings, nonverbal cues, and how I can frame information to support therapeutic expectations. Overall, the PANACEA course helped me to better understand the therapeutic power of verbal and nonverbal communication in everyday care, and that my relationship with a patient can be just as effective as a medical treatment. And moving forward in my career, I hope this understanding will improve my ability to maximize benefits using placebo effects and minimize harm from nocebo effects. Lastly, I would like to thank Professor Matarozzi for organizing and carrying out the course. It was a pleasure learning from her expertise. Thank you very much.
Thank you, Ehsan. Very, very insightful. Thank you for sharing those. Really appreciate it. I'd also like to move online slightly across to Marek Oleszek. I hope I've pronounced your wonderful second name correctly, but welcome. Thank you so much for joining us. We'd love to hear your insights.
You have to let me a sign that I can speak. There's no.
If you can hear me, you can go
hearing
ahead.
from the audience, or I had. I was following the conference on the another channel, but there's a huge delay in the signal, so there is no parallel. Okay, so just Nathan, can you give me a wave or something?
You can go ahead. Go ahead. Feel free to continue.
No, thank you very much for organizing this event, and thank you very much for giving me this 5 minutes to summarize 3 years of my life. It was a very busy time, and as probably you have, maybe you are not aware, but I am just of the few physicians in this team, which is mostly occupied by scientists and psychologists, and my professional and personal experience in here was that I was the first receiver of the materials we were we're planning to introduce to the students later and to other doctors. And believe me or not, that it was quite a difficult thing for me to understand what is really happening around. And it's really a great support from my team, Przemek and Anita, who introduced me so deeply in this topic in a very quick way. But when I look back to this project, I might say that there are at least 3 major achievements of PANACEA consortium. The one is this network of individual connections, and I mean that even in our university, we are working almost door to door with other colleagues, as I had my partners from the psychology unit, and I was completely unaware how advanced they are in the research, how deeply they investigated the placebo topic, and how much progress is already done in this topic. As for physicians, I think that psychology is something less scientific. It's something less serious than treating a patient with pharmacotherapy or doing some invasive procedure. But now, thanks to the PANACEA, we can show that psychology changed also a lot, and especially in this topic, it is a very hard evidence standing behind what we try to teach our colleagues. The other huge advantage, another bridge we were able to build in this project is this strong link between science and practice, and we have tried it on the students, and we have tried it on PANACEA days with other physicians, and I know how helpful those materials are in translating what is grounded in basic research into daily practice. And what we very often do, and what we believe is very important, like skillful communication, now we can say or prove our students that it is not only a mumbo jumbo or something which has to be done during curriculum, but something which is strongly supported with evidence. So this is a topic of placebo, which was, I guess, that in medicine it was quite a neglected topic, but it's also a broader approach to translating science into daily practice. So thank you for this opportunity to cooperate, and for all the achievements, all the products we are now able to offer the general audience, and I hope that they will find satisfied responders. Thank you very much.
Thank you very much, Marek, for sharing that. Really appreciate it. We have one more story that we'd like to. We don't want to bring it back in person. So we have our very own Céline Laby, who's joined us in person today to share some insights also. Céline.
Hello, everyone. I'm Céline Laby. I'm a physiotherapist, but also a clinical researcher from Belgium. And for more than 10 years, I've been working clinically with people that have complex musculoskeletal pain, and both in practice clinic, but also in a hospital rehabilitation setting. And my goal is really to help them to regain movement and to reconnect with what they really want to do and matters in their daily lives. Over time, I noticed something quite important. The way that we speak as a clinician and the words that we choose, the way that we explain some things, and the body language that we use really change how patients feel and how they respond to the treatment you want to actually provide. And I wanted to understand more about this and to be able to explain it clearly, to have a better view on the underlying mechanisms. And that's really what brought me to the first PANACEA summer school in Madrid in 2024. Attending the summer school was a really great experience. As you can see in the next slide, on the pictures, it was a mix of lots of different aspects in the week. During the week, we actually explored how to optimize placebo and reduce nocebo effects, learning how the underlying mechanisms can explain the brain and body reaction to expectations, beliefs, but also to our own body language as a clinician. And these sessions were really fantastic. They were fascinating because they connected directly with my daily work, trying as a physiotherapist to communicate and to do expectation management with a patient that really strongly influence how someone is having hope and how someone is recovering when people are suffering and living with chronic pain. We also provided some feedback on the learning models and on the new web app, which is really practical to use in your daily clinic as well, which made us feel involved in the process and which also were tools for using in the terms of future learners. Besides the lectures, we really enjoyed the group discussions, the team building exercises, and the interactive workshops that allow us to really transfer knowledge to skills and competence for directly integrating it into practice. And lastly, working with an international multidisciplinary group allowed us to really have a broad view on all aspects of how placebo and nocebo can actually be used in the different fields and settings. But back in the clinic, after the summer school, I started to think about how can I now apply these tools and these ideas in my daily work. And not only in what I say, but also how it shapes the treatment of the patient itself. So at the moment now, I'm very conscious and pay more attention to how I describe some exercises or the therapy that I propose to the patient to discuss those different aspects. And small changes in language really makes a difference. Like saying that a sensation is a normal feeling within a certain therapeutic exercise that can reduce the anxiety of the patients and increase their engagement in that exercise program. The patient feel more confident and they often it leads to a better result, more adherence to your exercise program, and that's obviously a good side. I also try to avoid negative framing, as we've heard, because it can create those nocebo effects when patients expect more pain or poor results. So that actually make the experience even worse. I try to incorporate the education of placebo and nocebo for the patient to help them understand that their expectation and mindset might affect also their outcome. This makes the care more collaborative with the patient, so it creates really an active role and it allows them to engage in their own recovery. The presence and attention are also very important as a clinician. Small gesture, the poses that we apply, and also the eye contact really create some trust and relationship. Those connections make the patient feel safe and supported, which is a really important aspect of the therapy. Finally, team communication matters. When all healthcare professionals use positive and consistent messages, it really feel more reassured for the patient, and the patient can follow the plan or the proposed plan easier, and it helps also for them to recover more efficiently. So these elements that are shown now on the slides are small but mindful changes that can be done in communication in the daily work of all healthcare providers, and that significantly can improve the treatment outcomes of the patient. So looking back at the PANACEA, it really reminded me as clinician that we always have influence on placebo and nocebo effects, even if we are not realizing it. And the key is to use that influence ethically, consciously, and to make it and to use it with compassion. I'm deeply grateful to the organization and the whole and entire PANACEA team to have had the opportunity to learn, to connect, and to grow. And at the heart of healthcare, it's not just about what we do, but it's how we are present, what we speak, how we speak, and how we listen. That truly makes a difference for our patients. And that's an important message that needs to get across for all colleagues, of course. Thank you very much.
Thank you, Selina. Thank you for everybody for sharing your insights and your experiences. I'd now like to thank you for hanging in with us, by the way, for this far. We've got to the good part now. I'd like to take the chance to open the floor for a discussion where we can invite people to the stage and we can pose those questions that have been written online and, of course, in today's audience as well. So for the online participants, so if the panelists want to take their seats and get themselves comfortable, we'll grab you some more chairs as well. We'd like to open the questions from the online participants. Again, you can do that. We can see that there's been a few in the Q&A section, which is brilliant. We have around 20-25 minutes, so plenty of things to discuss. Please let us know if you have any questions. This is a real good opportunity to pose questions to our panelists who are today right in front of you and have their undivided attention, which is quite rare. So moderating this section, Johan Vleyen, thank you so much for being involved, Johan. You will be taking this section forward, and of course, please ask your questions to our fantastic panelists.
Thank you, Nathan. So my name is Johan Vleyen from KU Leuven, Maastricht University in Belgium and the Netherlands, and I'm will be your moderator. So I would like to invite you for questions, both from you here present, as well as everyone online, of course. Maybe if I may, just as a kickoff, and then maybe this also facilitates the other questions as well. Maybe a question for maybe Katja or maybe also Presham. When I was looking at definitions of placebo many years ago, well before the PANACEA, the word inert treatment comes up very, very frequently. And I was wondering, after all this experience and the work that we've been doing, should we just ban that word now from the definition? Inert. Because all we hear, it has more to do with communication, psychology, expectations. So that's not inert, is it? I don't know. Presham, do you would like to start?
Yes, I think the contrary of inert. There are a lot of things inside, of course, but you agree that the common meaning of people is just inert treatment. So, but we work in order to change this mental representation on healthcare professional, the current and the future. And maybe why not? I don't know if is the exact place to introduce this, but I remember that we discussed a lot also with Johan about to change the name. So to change the terms placebo in something different. I don't know if you Shamek, you want to add something.
Well, Actually, I wouldn't abandon it because I think that inert placebos are a great model to study placebo effects. So actually, we use inert placebos or pure placebos, however we call it, as a model of studying with controlling all the other factors. So for me, placebo is like one of the examples. Inert placebo is like one of the examples of a broad term of placebos. But of course, there are some. In literature, some the authors propose, for example, to use contextual healing instead of placebos, and then inert placebo is just a part of the contextual factors. But I think it's just like it's probably easier to for communication to still use the label placebo, because then everybody it's like. I don't think that changing it is now possible because there is such a long history of studies on placebos. And I think that now redefining placebo is much more convenient than changing the name.
I was more thinking about the term inert, not so much.
Oh, inert, okay.
Yeah, right.
Okay, maybe we pharmacologists may be guilty for that term. We are the guilty part, because of the definition probably provides or comes from the absence of an active pharmacological substance. So maybe it has been defined by what is not present and not what for what it is. And nowadays, I guess that it could be changed. Of course, there's not an active pharmacological substance, although it could be, but in some cases, but it should be defined for the positive things that are present in the placebo effect or response.
Yeah. Thank you for sharing your ideas about this conceptual issue that is going around in these days. Any other comments from the other panelists? No? Maybe another question there. Yes.
Yes, great. Thank you. So we have some questions online. So Yvonne asks, do you know whether negative expectations can effectively be improved despite strong perceptions?
Question for the mechanisms? Oh, Stephanie?
Yes, of course. So whether negative expectations can be improved, I think this is something that can happen. We know from research that even if people have bad experiences, if they are conditioned to a certain negative effect, you can recondition them and reverse this nocebo effect. So it is possible. If the negative expectations are really strong, it might be more difficult, so they might need more positive experiences, but it's, I think, definitely something that can be done.
Yeah, so actually more specific, sometimes you get a patient referral and you notice that the patient already has significant nocebo effect. Is there a way to deal with that? How can you reduce the nocebo effect that is already there?
So, yeah, there are a couple of ways to do that. So I guess it also really depends on the case. So sometimes it's possible to change, for instance, the treatment type, treatment vehicle. Again, depending on the case, but it could be that if a person has negative experiences with option A and there's another option B, then it might be good to offer that and to really explain the differences as well. There are also other ways to do it. So you could also provide information on the mechanisms of the treatment. For instance, it might be that people just don't know what's going on, what's supposed to happen. They might have these unrealistic expectations, which if you are able to transform those to more realistic and well, optimally positive expectations, of course, then this can also be really helpful. Yeah.
Thank you, Stephanie. And of course, we also have some evidence from psychology, and we know that, for example, exposure is a treatment that very actively can change the expectancies. It's just by the experience of seeing different consequences is a very powerful method also to modify the negative expectancies, in addition to verbal information and so on and so on. Yeah, thank you. Another question.
We do.
Yes, online.
Yes, it's popping off, as we would probably say. Another question. Can patient organisations access the material and learning modules? And a little kind of add-on to that is, will the modules be updated when new research is published?
Yes.
Yeah, of course, patient can access the web app. It's free and available for everyone, so they just need to register and that's it. And also we plan to, of course, update the web app, the learning materials and so on based on the evidence, of course.
Fantastic. And I think there's a link to the web app coming a little bit later on, a bit later, so people can scan and access that.
Yeah, yeah. Thank you.
Yeah, so the idea is that it's free, available for everyone interested. Yeah, right.
We have one from Lars, which says, I'll read the comment. It's fantastic. Randomized control trials suggest that paracetamol provides no statistically or clinically significant benefit over placebo for acute, non-specific low back pain. Is it accurate to interpret this as evidence that paracetamol has no pharmacological effect in this condition if it equals the effect of placebo that is clinically relevant? Could paracetamol still be indicated in patients with anxiety, negative expectations, pain perception, essentially that blunts the placebo effect?
Question for... Yeah? Well, you mentioned these studies. So
Yeah, I mentioned it. When there is no difference between active treatment and placebo, it doesn't mean that active treatment doesn't work, because placebo works. It depends on whether there was another group without any treatment, neither placebo nor active treatment, which we call natural history. And if there is a difference between these groups, so the group natural history and placebo, and natural history and paracetamol, we can only say that there is no difference between placebo and active treatment, but we don't know actually the mechanism which stay behind the paracetamol effects. So I wouldn't, based on this kind of studies, I wouldn't say that paracetamol doesn't work. Whatever I can say is that the effectiveness of paracetamol is not bigger than the effectiveness of placebo effects. But maybe Antonio can correct me.
Well, you're right. And this comes into the question, comes to the table, another question that is that for clinical trials, an excessive placebo effect could be counteracting for clarifying or to evidence the effect of drugs. So for that reason, for clinical research, we need to try to avoid placebo as a bias that could affect the evaluation. Of course, if placebo works, it's good for patients, but under this framework, it could be a huge problem to evaluate drugs. And drug evaluation is needed for the future.
Yeah. Yeah.
If I may just add, based on this study that I mentioned, but also the other studies concerning paracetamol and low back pain, paracetamol is not now, it's not recommended for treating low back pain.
Yeah, that's correct. Yeah.
Another question is that to solve the problem, you would need to add a third arm with no treatment or or to add a comparison to be sure that if it is an excessive placebo response or an absence of drug activity.
Right, yeah. And if I don't know if in that study, but both did better than the natural history, or
Well, actually, I don't remember it as well.
Okay.
Whether there was a natural
No.
history, because actually this was not a study. This was a meta-analysis, a Cochrane meta-analysis, and I don't remember whether there was a natural history group.
Yeah, right. Because that would be an interesting case where suppose that both would be better than natural history, would then be the placebo be considered inert? So coming back to my first question.
Yes, but I can add, if possible, I can add, because I remember from the other studies on antidepressant drugs, because in these studies, and there are a couple of, actually dozens of meta-analyses, and in which there were active antidepressants, placebo antidepressants, and natural history.
Right.
And what we know from this meta-analysis is that active antidepressants works a bit better than placebos. Actually, the difference between placebo group and active treatment is 3 points on Hamilton Depression Scale, which is from 0 to 51. So from clinical point of view, this difference doesn't matter at all. It's statistically significant, but actually meaningless for clinical practice. But both groups are superior to no treatment.
Exactly. Yeah.
And based on this, we cannot say that antidepressants are placebos. We can, or they didn't work. We only can say that they work just a little bit better than placebos, and we don't know, of course, why.
Okay. Thank you. Thank you for clarifying this. Another question from the audience, and then another question from online, I think.
So when you're a lot of placebo is about expectation and managing expectations and setting positive expectations, how can you avoid going into sort of like toxic positivity?
Is that who would like? And then there is another.
I can give it
there.
a go. Yeah, yeah. So I think here the interaction is really important. So picking up on cues, like in the recommendations, we also do mention this aspect that you don't want to exaggerate treatment effects, that you don't want to be too positive. You have to be realistic. But I think approaching a consultation with like optimistic realism, this is the way to go. So you don't just mention positive things, because that can also violate trust of patients. If you're just positive, they won't trust you anymore. So it's a balance, and I think it depends a bit on the individual, like to what side of the balance you have to lean. But yeah, you're definitely right that you should avoid just being overly positive.
Yeah, trust and credibility is very important. There was one online question, and then we have a question here. Yes, okay.
That's great. So we have from Dave, it's kind of a two-part. Will the systematic review in the guidelines page be published? And have explanatory frameworks such as Bayesian or active inference been included in the content?
Okay. So the first question about the publication, is that something that can be confirmed, I think?
Yeah, of
yeah,
course.
right.
Yeah,
Sure. That's, yeah, right. And the second question, can you maybe repeat?
Yeah, have explanatory frameworks such as Bayesian or active inference been included in the content?
They are included. So actually, in the second model on the mechanisms, they are included. I didn't have enough time to cover all the issues concerning mechanisms that are included in the materials, but this Bayesian approach is included.
Okay. Positive. There was a question here from the audience.
It's not really a question. I would like to come back to your first question, the challenge to the panel. concerning the term inert treatment. And why put I the question here? It is because I was involved in developing a glossary for the UAMS, and it's very striking how same words are interpreted completely differently in Europe. So it was really difficult to make up a glossary and get an agreement all over the countries and say, okay, we can work with that. I think in the term itself, inert treatment, that is completely a contradictio in terminis, because treatment because doing something, moving something to a wished for position, and inert means that nothing is moving. So I think in the essence of the term, it's not correct. So we must stay away from semantic discussion, I think. If you speak about inert treatment, then I completely agree that this is a functional term for clinical pharmacology. I don't think that is a useful term if you talk about placebo, because if you use this term and you take it out of the whole of the context, this holistic approach that you have shown us today, and I highly appreciate it being a psychiatrist and a former general practitioner, I think that treatment is everything you do. Not only drugs, but also your behavior, non-verbal, verbal behavior, etc. So I would be in favor to speak about treatment and keep the term inert treatment for what you clinical pharmacologists are staying for. Thank you.
Yeah, it's wonderful that having this discussion beyond the outcomes that we have produced, this is a more conceptual discussion, and it's wonderful that we can have this also in the context of PANACEA and beyond that, hopefully. I think we have to respect our timeline.
We're very close to the end, but can I just say one thing quickly? So we've got Mark here and Pedro, who respectively are coming from UEMS, who represent the qualified medical specialists. Very powerful and very important organisation at European level in terms of setting the educational training standards of the different disciplines. And Pedro, who's here from the European Medical Students Association, so representing the next generation of medical professionals. And I just wanted to get your two reflections on the importance of the event and the importance of improving education on this subject for your communities. We'll start with you, maybe, Mark.
I've learned something today, and I will bring this back to the executive and introduce the subject and the learning materials into the whole of UMS. So many thanks for the invitation again, and thanks you all of the panel, because it's a challenging story. And okay, I always say I was born 20 years too early because I'm a specialist in transition psychiatry, and only now psychiatrists start to realize how important transition is, and treatment is creating transition. So many thanks again. Peter, up to you.
Thank you very much once again for the invitation and for all the panelists and for what I've learned today. From what I learned and what I think it's implementable in NEMS as well is this top-down approach that where you give materials to the professors and you give materials to the schools for them themselves to do the changes. What I think as EMSA, what we can also do and what we do regarding medical education is also approaching directly the faculties to make changes, long-term changes in the medical curriculum. Because at least for me and from what I've learned today and from previous experience, placebo and this approach, which is not just placebo, but it's just soft skills and patient approaches and just communication, it's not something that's placeable in only a subject. It is a multidisciplinary approach that needs to be implemented all across curriculum, be it horizontal or verticality. And I was very, very pleased to say, and I have to compliment you for the inclusion of students in the whole project. And we saw today that they saw changes in their approaches to patients and in how they felt comfortable in their clinical practice. And this shift from just having having this theoretical knowledge into practical concept and practical practice it's crucial. So I want to thank you for that.
Thank you. We have probably a whole series of questions still laying before us, but we don't have the time.
No,
unfortunately.
we don't. Thank you so much for your engagement during the panel, of course, through the questions throughout today's session. I'll invite the panelists to retake their seats back in the audience. A round of applause for the panelists. Thank you so much for that. Again, thank you so much for your questions. I apologise that we've not been able to answer all of them today, but it's been very, very interesting discussions. I'd like to now head on with Katja, invite Katja to deliver some key messages, takeaways, and we will round off the session. Thank you so much.
So thank you. I have no idea about the time, so I have 5 minutes to close. Okay. Okay, thank you. So as we conclude, I'd like to draw your attention to some key challenges, recommendation and direction in the field of education on placebo-nocebo effect to bridge the gap between scientific evidence and clinical practice. So firstly, dissemination and integration of the developed educational formats remain critical, and this includes incorporating the placebo and nocebo training and courses that PANACEA developed outside of the partnership, so into core curricular with the particular emphasis on the content integration and the development of joint or collaborative courses across university. And there is also a need to modernize academic CVs by including, for example, micro-credential, which can serve as flexible and lifelong learning opportunities for future healthcare professionals. So overcoming regulatory constraints and fostering multi-stakeholder dialogue among researchers, educators and policymakers is essential to support this integration. And secondly, evaluating the effectiveness of this educational intervention in clinical practice represent a vital next step. So developing standardized assessment tools and designing implementation research are crucial to demonstrate real-world impact and scalability of what we produce within PANACEA. So, and while working on PANACEA and translating the evidence on placebo-nocebo effects into clinical practice through education, it became clear for us that this alone is not enough. And it's essential to involve another key player in this dynamic. So not just the healthcare professional, but also the health consumer, our patients. So we needed to ensure that patients become aware of this phenomenon, laying the foundation for a more open and facilitated dialogue between healthcare providers from one side and those they care for, so our patients. So empowering patients with reliable knowledge about placebo-nocebo effects can ultimately improve patient engagement, adherence, and health outcomes. So the near future for us, starting from December, so in less than 1 month, will be focused on a new project founded by the European Union called ECHO. And this initiative aims to promote evidence-based knowledge about the placebo-nocebo effect among healthcare consumers. So while it addresses the same themes, the same subject, the target audience is different, requiring the development of new tools. So about the question from the virtual audience, yes, of course, our material that we produce with PANACEA is open also to the patient, but we have to targeting, individualized, tailoring the material from the patient. So the ultimate goal is to improve clinical practice and achieve the best possible outcomes from therapies thanks to this two huge project and thanks to our partnership. So I'd like to invite all of you here today to use the PANACEA educational tools and to spread as much as possible the educational formats. So starting from today, to integrate these subjects into the education of future and of today healthcare providers. So all these resources are free, accessible to the PANACEA web app with QR code you see here, and you can scan it now and register and gain access to your earliest convenience later, but just scan at this moment in order to add the link on your device. I don't know if I give enough time to scan the QR code. Maybe yes. So I'd like to thanks, of course, all members of the PANACEA partnership who are here today with me, and of course, members that are not here today, but we have a very, now we are friends also, and we hardly work on this project, and I think that we can be proud to reach this result. And I want also to thank students and healthcare professionals that joined the educational format and take time to share the perspective with us. And of course, I want to really thank the EFIC to organize this conference in a very precise way. So all works perfectly, so thank you so much. And I wanted to thank Nata to moderate the session and to be interested in the topic and to learn with us a lot of things about placebo and nocebo. And I want to thank Ariana Bagnis, that is the project manager of the PANACEA, and because we really thank her to be on time all the time, and also Barbara Vetturini, the European project expert from the University of Bologna. Her contribution was absolutely important in order to get founded 2 times, so I have to really thank. So, and I really thank any of you here in person and also virtually for your interest and attention, and I give the floor to Nathan just to conclude our meeting. Thank you.
Yes, thank you, Katia. Very, very well rounded off. So again, as I mentioned, thank you so much for joining us both in person and of course everybody online. Before you disperse, we would love, of course, naturally, some feedback. It's the favourite part of everybody's day. So if you could please just give that QR code a scan and provide us with some feedback so we can obviously make these experiences better in the future. We would really, really appreciate that. Again, I would like to just expand the thanks to all the partners within the consortia and, of course, the work that's been done over the past few years and will continue to happen in ECHO in the next few years as well. Thank you so much to our online audience. Please scan the QR code and enjoy the rest of your day. I was going to say virtual day, but it's very much a real day, just in a different place. But everybody in the audience in person, we obviously have a social event for some coffee and some discussions after. Please join us there. And I thank you again for joining us all today. Thank you.